All right. And since this is our last session, first of all, thank you everyone for being here. Thank you to those that are listening later. That is probably going to be the majority of our listening audience. I'm viewing this at a later time. I will quickly review. We are Minnesota Project Scope. Those of you who've been here before know us well. It stands for Supporting Children of the Opioid Epidemic. Just a few quick bullet points that I talk about every time. We focus on neonatal abstinence syndrome, or the more common neonatal opioid withdrawal syndrome. We're a community of early intervention providers supporting children and families, and we use the ECHO training model. Next slide, please. And here, if you just look at the slide, what is ECHO? It stands for Extension for Community Health Outcomes. We're basically a community of practice. We're different than a webinar in that we all learn together. We have expert presenters here today, such as Chelsey Ackerman from MDH, from Minnesota Department of Health, but then we also have many experts in our audience telling us about what they're seeing in their communities, and we learn together. Next slide, please. 4 principles of an ECHO model. We use technology to leverage scarce resources. We use best practices to reduce health disparities. We really consider ourselves a bridge in these sessions between the education world and the clinical world, or the policy world as well, which is what we may be talking about. We share a family story, and we use data out to monitor outcomes. And this is our final session, session 8. Today is December 22nd. Believe it or not, we are here. And we are meeting our goal of doing 8 full sessions. And today it is the opioid crisis in Minnesota and social determinants of health. Quick glance at our schedule, and then I will introduce our speaker today. Thank you so much for coming today, Chelsey. We have Chelsey Ackerman. Chelsey is an overdose prevention administrator with the Minnesota Department of Health's Overdose Prevention Unit. And thank you so much. You're going to be talking about the opioid crisis in Minnesota and the related social determinants of health. This is the first time you've been to our Minnesota Project Scope, and we wanted to give you a warm welcome. And thank you so much for coming and sharing your knowledge and expertise with us. Thank you so much. And with that, I'm just going to turn it over to you. And I think, is Drake running your screen?
Yes,
okay, great.
Thank you.
You guys already taken care of. I will just sit back and listen. Thank you.
Thank you. I appreciate it. That was such an awesome introduction. And that's what I was going to do. And now I'm like, well, everybody knows. So I am Chelsey Ackerman. I am a part of the overdose prevention team over at MDH. And today I'm going to talk to you about the opioid crisis in Minnesota. So my goal for today is that by the end of the presentation and at the end of our time together, that you will all have an increased understanding of the history of the opioid crisis, a primer on the social determinants of health and substance use, and then a general sense of the landscape of opioid use in Minnesota. So before we begin, I do want to take a few minutes to frame up the conversation. Substance use disorder, including opioid use disorder, is a preventable and treatable chronic condition, just like diabetes and asthma. Substance use disorder does not occur in a vacuum, and it can impact anyone. So when we think about stigma around substance use disorder, this usually presents as negative associations and feelings toward people who use drugs, and this can often lead to social isolation and barriers to accessing healthcare and treatment. It can also increase an individual's vulnerability for drug overdose and other drug use related harms. This stigma can also decrease the pathways to recovery resources. And this is why the language that we use when we talk about substance use and people suffering from substance use disorder is so important. We all have a role to play in decreasing stigma surrounding substance use by using person-first language. And this phrase, person first, it simply means acknowledging the humanity of an individual before defining them based on the health conditions they experience. Some examples of person-first language to incorporate in your vocabulary include person who used drugs, person who injects drugs, person in recovery, or person living with opioid use disorder. Some common stigmatizing phrases or words that you should avoid include opioid abuse, drug abuser, an addict. And it's also important to note that anytime you're working with somebody with substance use or misuse, that this language can change quickly, and just taking that opportunity to either follow their lead or ask them directly what language they prefer is generally best practice. So what are opioids? Opioids are a class of drug that includes both illicit and prescription medications. Opioids are often prescribed after surgery or injury or to relieve cancer pain. Common types of prescription opioids include oxycodone, commonly referred to as Oxycontin, hydrocodone, also known as Vicodin, morphine, fentanyl, and methadone. Common types of illicit opioids are heroin and illicitly manufactured drugs that replicate the effects of prescription opioids like oxycodone and fentanyl. So opioid misuse is use of any opioid for a purpose not consistent with legal or medical guidelines. An opioid use disorder is a formal diagnosis of opioid dependence, and an umbrella diagnostic term for dependence to any substance is called substance use disorder. So here on this slide, we can see the injury pyramid. And while death is one of the most profound impacts on this pyramid here, there are many other harms associated with drug use. So death from overdose results not only from a singular time of using substances, but it can represent a series of substance use pattern, frequently rooted in pain, trauma, and suffering that we see here towards the base of the pyramid. As I mentioned previously, substance use does not occur in a vacuum. No one generally wakes up and says, I'm going to start utilizing substances today and use it in a risky behavior. And just for additional context, for every one opioid involved death, there are 2 opioid related hospital admissions, 4 opioid related emergency room visits, 7 opioid related EMS runs, and 30 opioid related treatment admissions. So when we think about who is impacted by the opioid epidemic, what we're actually thinking about is everyone who has ever experienced pain, trauma, and suffering, or who may experience pain, trauma, and suffering. And everyone who knows, works with, or loves an individual experiencing this can be such an understatement to really understand who is influenced and impacted by the opioid epidemic directly or in some way. So looping back, one of the questions becomes, what created this demand for altering substances in the first place? So I'm going to kind of go into some of the history of opioid use in the US. And while opioids have been getting a lot of airtime in the media and policy attention in the last 2 decades, opioids have been widely used in the United States for over a century. Over the next couple slides, I'll go through that history and then some of the regulations in the US and how racialized policies have impacted and influenced the opioid epidemic. So in 1895, Bayer began the production of diacetylmorphine, which was coined the name heroin. And this was described as being safer than morphine. And then at the beginning of the 1900s, there was widespread heroin use across the US and no federal regulations addressing the increased rates of heroin addiction. Doctors and pharmacists were free to prescribe heroin and other opioids at their own discretion. So the federal government took steps with legislation requiring federal regulations, starting with the Pure Food and Drug Act in 1906. This allowed the federal government to regulate medication prescribing, followed by the Harrison Act passed in 1914, which taxed doctors and pharmacists for prescribing opioids. The first federal legislation criminalizing heroin passed in 1920, and that continued to become increasingly criminalized through new bills through the 1960s. This included the landmark 1951 passage of the federally mandated minimum sentence for purposes and sale of heroin. In 1971, US President Richard Nixon publicly declared a national war on drugs, and the establishment of the Federal Drug Enforcement Agency quickly followed in 1973. This declaration wrapped up US efforts in spending to enforce drug law, increasing prosecution of both drug sales and possession. One item to note is that the war on drugs is widely accepted now as a racialized policy that disproportionately charged and incarcerated people of color who used bought and sold substances, resulting in the disproportionate incarceration rates we see today. Then in 1986, the Reagan administration increased punitive law enforcement efforts focused on people who use drugs, establishing a zero tolerance law for illicit drug possession. And then simultaneously, by the late 1990s, pain was declared as a fifth vital sign, encouraging the promotion of dispensing opioid prescriptions. In most recent history, federal funds under the Obama, Trump, and Biden administration have dedicated a mixture of prevention efforts, including law enforcement, treatment services, and overdose emergency. So from 1999 to 2019, nearly 500,000 people died from an overdose involving any opioid, including prescription and illicit opioids. And when we think about the opioid crisis, we tend to think about it in waves that we see here on this slide with this chart provided by the CDC. So in that first wave, we began to see the increased prescribing of opioids in the 1990s, and many of the overdose deaths during this wave involved prescription opioids. The second wave, which is that darker blue box there in the middle, that began in 2010 with a rapid increase in overdose deaths involving heroin. And then by 2013, that third wave began, the purple box there, with significant increases in overdose deaths involving synthetic opioids, particularly those involving illicitly manufactured fentanyl. And it's important to note that through these waves, that many of the opioid overdose deaths also included other drugs. So it's not necessarily unique to these drugs that we've been discussing today. So one of the implications we have to think about, and we're starting to see through our preliminary data, is the impacts of COVID that it's had on the opioid crisis. We know that COVID's been incredibly hard on individuals, families, and communities. And unfortunately, with that came reduced access to treatment, isolation. Many of us watched as deaths increased nationwide, and our epi team is beginning to see that impact of COVID on the opioid crisis here with preliminary data that's coming out. So circling back to racial disparities previously noted from Reagan's war on drugs, until the early 2000s, the media primarily associated use of illicit drugs with communities of color dating back at least a century. And the use of opium and opium dens was mainly presented as occurring in Chinese immigrant communities. And media has long portrayed people who use drugs as ethnic minorities and people more likely to commit crimes, be violent, and live in urban areas. The crack epidemic of the 80s and 90s was portrayed as impacting communities of color. Over the last decade, there has been substantial pooling of resources into opioid prevention and treatment through state and federal government sources. And there has been a notable shift in our culture that opioid addiction is something to be treated and viewed compassionately. And this different perspective and approach to treatment rather than punishment did surprise and sadden communities of color who didn't receive the funding and attention that was essentially triggered by white communities and users who are receiving presently. Excuse me, I apologize. Admittedly, there is still a long way to go in providing treatment in equitable and destigmatizing ways. This is something that we ask all of our communities and partners and funders to think about when we're thinking about how to improve treatment access, especially culturally specific treatment among communities of color, and how to be sustainable and help influence to close this disparity in access. Heroin and opioid use is not new among communities of colors, yet many stories of successful recovery highlight white people from rural areas who found themselves addicted to opioids following prescriptions from a medical provider. Opiate use resulting in deaths among communities of color prior to what is known as the first wave of the opioid epidemic, but the waves of the opioid crisis themselves are centered on increase in use among white people. The lives that were lost to opioid overdose prior to the identified first wave mattered and still does matter. So when we start thinking about social determinants of health, we know that health starts where people live, learn, work, and play. Conditions of life are connected to healthy outcomes, especially when it comes to the treatment of chronic pain, mental health, and trauma. And social determinants of health are the conditions within a home, family, school, and community that can impact a person's ability to be healthy. Social determinants of health can include the physical characteristics of the neighborhood where a person lives. It can be having access to healthy food, safe housing, having quality education, and having economic well-being. So this graphic is another one borrowed from the CDC. And here on the slide, we can see how the social determinants of health have been broken and grouped into 5 different domains. So we can see here on the slide, we have education access and quality, healthcare and quality, neighborhood and built environment, social and community context, and economic stability. And social determinants of health do have a major impact on people's health, well-being, and quality of life. And just to kind of reiterate, some of those examples include safe housing, transportation, feeling safe within a neighborhood, having access to job opportunities, income, access to nutritious food, physical activity, having opportunities to access to parks, green spaces, and that exposure to pollution, racism, discrimination, and things of that nature. Social determinants of health can also contribute to health disparities and inequities. For example, people who don't have access to grocery stores with healthy foods are less likely to have good nutrition, which can then raise the risk of health conditions like heart disease, diabetes, and obesity, and even lowers the life expectancy relative to people who do have access to healthy foods. And another important factor that influences social determinants of health, which I imagine many of you are familiar with, is adverse childhood experiences, or ACEs. So ACEs are significant social determinants of health that have been linked to an increased risk of mental health issues and substance use. ACEs can be grouped into 3 categories shown here: abuse, neglect, and household dysfunction. And ACEs are also incredibly common both nationwide and in Minnesota, with an estimated 40% of Minnesota students experiencing at least one ACE. There is a dose response with ACEs, so the more one has, the greater the risk of negative health outcomes. And there's also an association between the number of ACEs one has and their race. In Minnesota, students of color are more likely to have multiple ACEs compared to white students, and the higher likelihood of ACEs among students of color is closely connected to social determinants of health and racism. When we think back to the injury pyramid that we saw earlier, to frame this conversation, we can place ACEs in the base of that pyramid in that lower level of pain, trauma, and suffering. So to tie this together, the social determinants of health, ACEs, and substance use, let's take a look at this social ecological model of substance use that we see here. Social ecological models are used to help us get a better understanding of the multiple and different levels at which a person's health is impacted, and it's kind of like a nesting doll. This model considers the complex interplay between individuals, interpersonal, community, and societal factors that we see here. And it shows some of the potential social determinants of health that may influence substance use, including a sense of personal safety, safe housing, supportive parents, a safe neighborhood to live, and affordable health insurance. So if we wanted to trace how a societal level factor could influence an individual's health, we can take a look at this STEM model that we have here. And we're going to start on the very far right with the societal level, which includes government, institutions, and systematic structures. So at this level, we might have a legislation that supports syringe service programs, medically assisted treatment providers, and the expansion of behavioral health services. And this is where legislation can be created. This would be created at the societal level by a government with authority over a specific geographic area. And then moving onto the left to the community level, here at this level, we can trace how legislation that support MAP providers could increase access to that medically assisted treatment within a community. As more providers and clinics become licensed, there's that increased access to this service. And then within that interpersonal level, we could see a greater acceptance of medically assisted treatment and how this can influence how services are viewed, if it's being utilized by a social group. And then this can also play into how our friends, family, coworkers, how they're supporting that health-seeking behavior. And then finally, on that far left, with the individual level, the availability and acceptance of withdrawal symptoms with management using MAT can impact a person's likelihood of maintaining abstinence from substances. So without having changes in legislation and having greater access to medically assisted treatment in the community and acceptance by that social circle of feeling supported, an individual may not have even been able to access that medically assisted treatment at all. And stigma, as we talked about earlier, does play a significant role at all of these levels. And that's why it's so important for us to try to incorporate prevention work that involves stigma reduction within all components. So now that we've shared a frame from which we can view opioid data and consider how social determinants of health impact substance use, I'm going to share some data specific to opioid use in Minnesota. Opioid data comes from a few different sources. I definitely recommend checking out the Minnesota Department of Health opioid dashboard. We have a lot of great resources there, but a lot of the data that we use primarily comes from hospital discharge data and death records. And this helps us better understand substance use trends, but this is also why we tend to see a lag in our data. So here on this slide, we have the non-fatal overdose chart from 2019 to 2020. And we can see here that the number of opioid-involved non-fatal overdoses has been steadily increasing since 2016. And there's been a substantial increase from 2019 to 2020. Non-fatal overdoses have unfortunately increased nationally during this time period as well. And currently, our preliminary state data does show that drug overdoses have increased nearly 27% from 2019 to 2020. It went from 792 to 1,008 deaths. And in March of 2020, when the impacts of the pandemic initially began, along with that first stay-at-home order in Minnesota, we saw a very large monthly increase of 64%. So it spiked up from 53 to 87 deaths compared to the 2019 trend line. The trend of each individual monthly drug overdose death total has been higher than the previous year, and this has continued throughout 2020, and we are finding a similar trend in 2021 with the preliminary data. So as this slide notes here, all of Minnesota did see an increase in overdose deaths. Also with that preliminary data, so we saw an increase in both the 7-county metro and greater Minnesota, with a very large increase in the metro. Overdose deaths increased 40% from 2019 to 2020. So that was a jump from 483 to 673 deaths in the metro. And greater Minnesota saw an increase of 21% from 2019 to 2020 and saw that increase of 276 deaths to 335 deaths. Here, this chart highlights that race disparity that we are finding within the opioid epidemic in Minnesota. So within Minnesota, African Americans are 2 times more likely to die of a drug overdose than white Minnesotans, and indigenous people living in Minnesota are 7 times more likely to die. So these differences in overdose rates among the communities are due to systemic oppression and in having inequitable access to resources. The race rate disparities in drug overdose deaths does mirror other disparities in Minnesota as well. So it's very similar to the trends we're seeing in graduation rates, infant mortality, incarceration, poverty, unemployment, and suicide. And in Minnesota, factors like systemic racism have prevented communities of color of having equal access to resources they need to be healthy. And that poverty, ACEs, intergenerational trauma, and intergenerational substance use are all social determinants of health influenced by systemic racism. So this chart here does expand on that disparity that's grown, and we're seeing that in that data. So that mortality rate disparity between Indigenous and white people continue to widen, and it's gotten worse. And from 2010 to 2019, the Indigenous mortality rate has almost tripled from 29 per 100,000 to 80.7 per 100,000, which is a 178% increase. And in the meanwhile, the African American mortality rate has increased from 11.7 per 100,000 to 20.2 individuals per 100,000, which was a 73% increase. And this is almost 2 times as high as the white mortality rate. So I know that was a lot of information to share, but before I leave, there are some key messages that I want to just reiterate and leave with you all today. So please, as we went through this presentation, I do ask that you just take with you that substance use is preventable and it is treatable. The opioid crisis does have roots in racialized policies, and we need to actively question and look at how we can address these inequities through response strategies. And finally, social determinants of health are directly linked to increased risk of substance use. And we just want to make sure that we're being considerate of all of these factors as we're looking to implement response strategies and work with individuals within our communities when we're trying to work through substance use disorder in the treatment space. And with that, I just want to say thank you all for having me today. And if anybody does have any questions, I'll open the floor to you. I also have my email there, so you can always reach out as well.
Great. Well, thank you so much, Chelsey. That was really a wealth of information. I know I always find it interesting, some of the history around opioids in our culture. And I think, is it Liz, your colleague, that had, did it used to be, did heroin or opioids used to be in Coca-Cola? I mean, that's what I remember from hers, or in some common.
Yeah, it definitely used to be in Coca-Cola, and there's actually like substantial history even well before the point of history that I've shared here, that you could go back even further to when it was morphine and like going into the Civil War. And it's just such a very packed and large conversation that's so hard to try to put it in such a condensed version. And I think that's what's so important of reiterating of this is a very complex issue and is far greater than simply that stigma that's coming around it still, that we're trying to help break away.
Right. It's just really interesting to think about some of the just common everyday uses it used to have.
Yes. Yep.
Yeah. I also, and I know this as a psychologist, I often get questions well outside of my scope, particularly around anything with medication. But I do have a question. As we look at opioids, and I think it's interesting, I've looked at some other histories of opioids, and they're talking about developing opioid-based painkillers that don't also that are non-addictive, right? Was that the hope with some of the more modern iterations of it? I guess, again, I know this may be outside of the scope of what you do, but why are opioids always sort of paired, that pain relief, with sort of the addictive qualities or the euphoric side? I mean, what can you tell us? Feel free to take the question in a different direction, but it's something I think about a lot, because that really didn't deliver with some of the more modern day iterations. They also were addictive.
Yeah, and I think that's definitely one of those challenges where that's where our prescription monitoring program came out of, was because that messaging and the way opioids were initially portrayed with pain management was that it was non-addictive.
Right.
And unfortunately, we've come to learn that it really has. And that's where we've started to develop these models to kind of help really put it back into the hands of providers for them to really reflect and think about, is this a really necessary prescription? And to start really monitoring how frequently it's being dispensed, to take a look at patients' profiles, to just really kind of help make sure there's not over prescribing to continue to happen. But it definitely did kind of come from the way that language and the way it was marketed, back in the early 1990s, that has really kind of unfortunately led to this point. And now we're trying to, of course, mitigate where we can, but it certainly continues to be a challenge.
Yeah, no, thank you. It's just interesting when you do look at the history and the different sort of developments within the field. So one more question, I'm going to turn over to the group. So as I told you, Chelsey, in the beginning, and I always ask this question so everyone can say it with me. Our group primarily consists of, those that we have here today, thank you for coming, as well as those who will view it later. They're early intervention providers. Typically, not everyone, but they work on teams. Sorry, I just swallowed wrong. Sorry about that. They work on teams. Sorry, we've had coughing problems on this project scope that have plagued us from the beginning. So sorry, I just swallowed wrong. I'm not sick, everybody, but you're not in a room with me, so there's no risk. But anyway, they're groups that work with primarily families in the realm of birth through 5. Some of them are early childhood special education teachers, some are social workers, some are OT. A fair number of them go into family homes because that's part of the model in Part C, early intervention, birth through 3. Some of them see kids within school-based settings. But either way, they're interacting and intersecting with the family system, as you do really with kids all throughout K-12 or preschool or birth through 21, but really pretty directly, actually. And they certainly work with families who have addictions or opioid use. Any tips or any takeaways for this group? I know it's general, but sort of what you see in your work. I guess I'm still wrapping my brain around sort of what your specific job is, but are there any just sort of words or wisdom or key takeaways for those that are really on the front line with families and children?
I think we're definitely acknowledging that the opioid epidemic and substance use disorder, it's not a space that can be navigated alone, and that there's multiple supports across sectors that need to be well integrated. And that can be a very challenging space to navigate, not only alone, but without being connected to those proper resources. So we're definitely finding that encouraging that ecosystem and building out those supports is something that we're finding in our work that we're really needing to help expand messaging on. But I think for me, if there's anything really to help as far as like words of support, is getting all of those tools to put in a toolkit as reasonably possible around this, because there is no one right way of working through this space and navigating it. So whether that's having fentanyl test strips on hand, or having naloxone or Narcan on hand, or working with a peer recovery specialist, and maybe there's some that are more specialized with family or offer housing or offer some of those wraparound services. It's definitely just trying to build out and connect with as many resources as possible to have readily available is going to be that best way of approaching it. And I think that's something that we are certainly acknowledging and recognizing within MDH, and really working to try to build out these more integrated, robust systems. But that's the best way that I think I could kind of describe some form of supportive language, because it's complex and it can be discouraging and hard, but you just have to really just try to persevere through it and really gather all that you can for resources.
Yeah. Chelsey, thank you. No, that actually is really helpful. I'm wondering, and I think as I understand your position, Liz last time talked a little bit about some of the it was learning for me around fentanyl strips, around access to them and use. I don't want people to overstep or go outside the bounds of where they're comfortable. But at the same time, she shared some information that was new to the group in terms of being able to access them and carrying them. I don't know if I'm even using the right terminology, but I'm wondering, one, if you could tell us a little bit about some of the kind of best practices and rules around that. And then I don't know if you have some resources you could put in the chat, because we always like to leave with resources.
Yeah, I can definitely put some resources in the chat. So generally when we get inquiries around fentanyl test strips or even just naloxone and Narcan in general.
I'm sorry. And yeah, I'm sorry. Clarification. I meant, I don't know why I said fentanyl test strips. I was talking about the Narcan. I'm sorry.
No, that's okay.
Why are you asking about fentanyl test strips?
That's okay.
Narcan
I like
is what
to
I
pair
meant.
both, to be honest with you. I
Okay.
prefer, if there's any way we can help individuals make more informed decisions when it comes to harm reduction, that's what we want to do. But there's generally a few organizations that we refer out, but we do have the naloxone finder, which is through Know the Dangers, and that has kind of a robust mapping of who is offering naloxone or Narcan. And then the Steve Rumler Hope Foundation does also have naloxone access points, which those are different organizations throughout Minnesota that are working with Steve Rumler to say, hey, I want to be a naloxone access point. Steve Rumler Hope Foundation helps equip them with fentanyl test strips. They equip them with naloxone and Narcan kits that they can then distribute out to the community. And then I do, Steve Rumler Hope Foundation does, they'll mail out these items as well. You don't have to go to a traditional brick and mortar to gain access to this. I think that's a big concern that comes from people who are out in rural communities. So there are ways of gaining access to these items without having to go into that traditional setting. And we're certainly trying to help get that out as widely distributed as we can throughout the state. But I will definitely, I'm not a great multitasker, so I will drop those resources in the chat here so that people have access to that.
Thank you, Chelsey. And I apologize for my confusion. I was thinking of the Narcan. We just learned when Liz came, she was sharing some resources about that, and we learned a lot more about it. So thank you. I didn't mean to confuse you, but apparently you're saying those are compatible in terms of also talking about the testing strips and things like that.
Definitely. I think they definitely are. I think it's, again, as many resources as you can have readily available in those instances, the better. And that's what I am all about. So
great. Yeah. Well, we have a very small group today. Thank you. Thank you, Chelsey. We just really appreciate you sharing with us both the history, the overview, the state of things in the state of Minnesota, as well as resources. Even just knowing about them is just helpful knowledge for all of us. So thank you so much. I'm going to open it up to the group to see if they have any questions. Oh, yes. Thank you. Again, this is just resources to learn about. Most of the people on here work primarily with children, but they do intersect with families. But I think it never hurts to know about resources. Chelsey, Stephanie, Drake, anyone have any additional questions for Chelsey today? Great. Okay. All right, Chelsey. Well, thank you so much. We appreciated having you today. Thank you for the resources. Drake will send out, we always send out a resource list that are the experts, the speakers that we bring in share with us so we can share with our community. Thank you so much. And we appreciate you coming this late in December. And we're just going to move on to our family story. You're welcome to stay, but you're also, your job here is done. And we just appreciate your time.
Thank you so much for having me. I appreciate it. I'll drop the couple other resources here and then I'll hang out because I'm curious.
That's great. Thanks, Chelsey.
Thank you.
All right. We will read our family story today, and we're just going to stay in the group. And I will read it. Hopefully I won't cough again. I think it's often this happens at the end of the day.
Don't worry about it.
Okay. If I cough, Drake will take over. Chelsey, we've come full circle. I presented the first session in September and had a cold, and Drake had to take I got through the presentation, but he had to take over the case study. And Drake, do you want me to read it, or do you want to?
Yeah, go for it. You can.
Okay, I can make it. I just had a little tickle in my throat and swallowed wrong.
Sure.
All right, so here's our family story. And Chelsey, in a true echo model, and Stephanie's been here before, we learn and then we apply our learning by talking through. The medical world calls it a case study. We call it a family story because we try and model a story that involves young children and families similar to the population with whom our early intervention providers will be working. So just a quick overview, topic areas illustrated in this case: trauma, drug exposure, child development, sensory concerns, self-regulation, behavior changes, and social determinants of health. You might see these are all topic areas we've covered throughout all of our 8 sessions of Project Scope. The age of the child who we're talking about today is 25 months. The setting, they live with their grandparents who are legal guardians, and it takes place in Greater Minnesota. Next slide. Okay, so here is just a little bit more background. The child's been living with grandparents since they were 10 months old. The grandparents had limited details on the history prior to that time, but their niece, the biological mother, was reported to have a substance use disorder. She used methadone and marijuana during the pregnancy, and the baby tested positive for both at birth, but had no significant withdrawal symptoms. Remember, we've talked about before, there's a wide range, a wide spectrum in terms of what a child presents with. And if we remember Dr. Precker, sometimes it takes a little while before they're seeing some of the visible symptoms. While mother worked on her recovery, she asked for the child to live with the grandparents, who agreed to be permanent guardians. They since accepted the child's biological brother, who was born 1 year ago, and came straight home with them from the birthing hospital. Mother is currently incarcerated, but wants to be as involved as she possibly can. What are the strengths, challenges, opportunities, and threats of your program? A developmental assessment of the child revealed motor, communication, and cognitive areas in the average range, and social, emotional, and adaptive areas in the below average range. Remember, I talked in mine about social, emotional, behavioral is often one of the significant areas impacted. The child was very friendly and easily engaged for the evaluation. The grandparents seemed to be very loving and supportive caregivers and have been great advocates for this child. The family lives on a farm in a rural area about an hour from the Twin Cities, so access to services may be more challenging. Primary concerns that were presented: the child is aggressive towards 12-month-old brother and towards the family dogs. She will pull tightly over brother's face and press it down, pull his hair, pinch his arms and legs. She kicks and hits the family dogs and roughly pulls their fur. When she doesn't get her way, she will stand and scream and clench her fists. There are sensory issues noted by grandparents, including dislike of hair getting wet when they try to wash it, seeking tactile input, pressure, and touching everything. One of our biggest concerns is with frequent fecal smearing, which usually occurs when she's in the crib, but can occur in other settings as well. And that is a tough one. Questions: how many social determinants of health inform this situation? What challenges and potential solutions could be incorporated? The caregivers report they need the most support related to how the child engages in some of these behavioral issues, such as the aggression and fecal smearing, and what strategy supports can caregivers employ or access. And then finally, what community supports or self-care ideas could be recommended for the grandparents who love the 2 children very much, but are tired? Keep in mind that they reside in a rural area.